Hi, class. Welcome to week 6. We are almost done. I wanted to let you know that next week will be the last live lecture as week 8. I usually don't post a lecture just because we have so much going on with capstones and things of that nature. So I just wanted to give you a heads up about that. So this week we're going to be talking about some content that is going to probably get some people kind of riled up. So this is the readings. There is a couple videos posted. These library e-resource access videos, if this one works for you, great. It may not. Don't be alarmed if it's not. You will still be able to answer the discussion board post. If it's not, the person who designed the course, it may have been a bit ago and there might be some issues with the library thing. So I just wanted to let you know not to be alarmed. I am aware that there could be a hiccup or two, but we are talking about transgender, gender identity, sexual orientation, things of that nature. And so this can be a heated topic, especially in today's culture. So the main thing is if you decide to become a licensed clinician, licensed professional clinical counselor, licensed marriage and family therapist, when you get a license, you are considered basically that you are going to abide by the law and ethics of the state or the government. And you might have some thoughts and concepts of like, well, I'm going to practice this kind of way. Well, once you get licensed, you don't get to pick and choose how you practice to some degrees. We don't do things that are out of our scope of practice. We're not going to say that we can administer certain kinds of treatments without the right expertise. We don't prescribe medication. These are things that we don't do because that's not legal or ethical. However, when it comes to ethics, you can't not see someone due to a sexual orientation. You can't not see someone due to a race or a religion or a transgender person. Like you can't not see someone due to those things. Some of these things you may not even know in an initial onset of meeting someone. You could meet someone that is has totally different morals and values than you. They might want, 3 partners and all live in a polygamous house. Like whatever. Like you can't say no, I can't see you because you're polygamous. Okay. So this is what I have to say, and I'm trying not to be too soapboxy, but I'm going to step on my little soapbox. Um, that it is God's job to judge, the Holy Spirit's job to convict, and our job to love. And I think as Christians, if we loved people a little more, we'd have a lot of different outcomes. Yes, when it comes to salvation, we are concerned about eternal life, and we want the people we love, we want people we know to go to heaven, right? That's what we're looking for, and that's what we're aiming for. But Jesus, God, the God man, when he was here on earth, he confronted people in a very loving way. He talked to people about things he did not agree with in a very loving way. He spoke truth, but he spoke it in love, and he spoke that same truth very directly to people who would appear to be religious, but were missing something. They were, whitewashed tombs. They look good on the outside, but the inside they were dry bones. So, for those of you who are Christians or call yourselves Christians, please be conscientious on how you treat other people. You can't disregard someone because they're different from you as a clinician. Now, we shouldn't do that in general, right? We're challenged a lot on how do we deal with sin that things we don't agree with that we would consider maybe sin. How do we handle that? But I think we have to take a really hard look on how we handle all sin. How do you handle the person who maybe is in a relationship that you would consider living together? How do you handle people who have sex outside of marriage? How do you handle gossip? How do you handle slander? How do you handle murder? How do you handle all these things that happen every day? How do you handle the thoughts in your own brain? We really need to dig a little deeper and go, by the grace of God, there go I. I could be anybody. And you don't know what's led people to make the choices and decisions in their lives. But we can have a choice to be light and maybe a really dark time for someone, we're not there to share our personal morals, values, convictions with our clients. Yes, we have to be able to lay our heads down at night and on our pillows and feel good about ourselves. But I think we just need to love people the way Jesus would want us to love them. And that may not be how you would handle something maybe outside of the therapy room. But I think we have to be mindful. We can't discriminate against people. That is wrong and that's unethical. So please, if you plan on becoming a licensed therapist, you are not allowed to discriminate because that's unethical. Now, you might say to me, well, I'm not dumb, like I know that. But a lot of people come into counseling thinking it's going to be a type of way, and it's not. A lot of different people go to faith-based counseling because it's cheap. I remember being at the Cal Baptist Counseling Center, and that didn't mean that we weren't exempt from things like divorce or affairs or homosexuality or all different kinds of things, drugs, alcohol, like all those things came through there, just because probably we were known for being reputable and we were cheap. So, people don't care. Like, you're going to be a therapist, you're a licensed therapist, you're going to be a licensed therapist, you're expected to practice what's expected of you. Okay. So please keep that in mind. Also, in reading some of the discussion posts as I have been each week, I noticed some threads have gotten a little snarky. At least, granted, I know maybe I'm reading into tone, but they seem a little snarky. And so with this subject in particular, you don't know what any of your classmates are going through. You don't know any of their experiences. You don't know anything about them really, other than what you may see through a discussion post. So please think twice before you respond in such a way where you could be being very disrespectful or rude. Also, you never know who you may need in your future. And so, you don't know who you may come across at another job site, at another facility, maybe needing somebody's help to get on at a job. So please be mindful of that when we talk to each other. We're all different. We have different life experiences, different expectations. We just have to be really conscientious of our tongue, even if it's typed. Sometimes we're way bolder in what we would say in discussion boards than what we would say to someone's face. Okay. And I get that a lot as a professor. I get some pretty intense emails from students that I don't think they would do that to my face. So I'm not saying any of you have done that. I'm just putting it out there, especially with this subject matter and how passionate we can feel on a lot of different views, just to know that we are people who are trying to learn, trying to grow, trying to figure out how to be the best clinicians we can be. And so please take that into consideration as you respond to people around you. Okay. So we're talking a little bit right now about gender dysphoria, and there was a couple different vignettes in here that I thought, this one was one that we kind of read about or hear about. So gender dysphoria is in the DSM. And it is in the DSM-5. So that is something to be aware of. And the DSM, if you don't know, that's our diagnostic manual. It's like the Bible of psychotherapy, okay? It's what we use to give diagnoses, okay? So gender dysphoria is not a sexual dysfunction. For adolescents it's an important part of a clinical picture for those who receive biomedical treatment. Now, for your knowledge, in a lot of instances, if you don't feel comfortable assessing someone to see if they should start the biomedical side of a transition, you are allowed to say, I don't feel comfortable with that. That's a big call. That's a really big call. There are a lot of clinicians out there that do feel comfortable with that. That might not be something you feel comfortable with, and that's okay. Okay. It is also okay to say to someone, if they ask you, what's your experience in a certain area, to say, I don't have a lot of experience. If you're looking for someone with a lot of experience, that's not me. That's okay to say to clients, because clients sometimes have those questions about a lot of different things. So it's okay to be like, I don't know, I haven't treated a lot of people in this situation, whatever the situation may be. So this is the example though here For children who present with DSM-5 diagnostic criteria for gender dysphoria, the age of onset of symptomology is always usually early, like preschool age, things of that nature. The core elements include a strong wish to be or persistent claim that one is the other gender. Other common signs may include cross-dressing, cross-gender play, and playmate preference, and sometimes marked dislike of one's sexual anatomy, like having a really disdain for their actual body parts. Okay. So in this situation, Robert, a 5-year-old boy, was seen for an assessment at the request of his mother. Robert lived with his mother and several older maternal and paternal half siblings. His parents, who were common law, lived together but were psychologically separated. Robert's mother noted that he had always been different from other boys. He preferred to play with girls. He engaged in girl play, would always take on female roles and pretend play like beautiful things, and did enjoy or play with stereotypical boy toys. He did not. Okay. His mother said that she had always thought his gender-related play was just play acting. The reason for referral was that at the age 3, Robert began to express the wish to be a girl. Most recently, Robert had begun to make statements such as, "I am a girl," and said to his mother that when he entered high school, she would tell others that he was a girl. These comments led Robert's mother to seek assessment. Apart from his mother's concerns about his gender identity, it was noted that Robert had a speech impediment, a variety of sensory sensitivities, and various signs of separation anxiety with Robert's mother. Were very attached, and that he slept at night with her, not in his own bedroom. Although he did okay at school, his mother noted that Robert would rather stay at home with her. When I met Robert and his mother for the initial assessment interview, Robert was noted to have long hair, was wearing purple nail polish, and had on purple leggings. My subjective impression was that Robert might well be perceived to be a girl based on gender social cues, such as hairstyle, clothing, nails probably. Early in the interview, Robert said that he had something to tell me. "I'm wondering if I was born a boy or a girl, and wanted to know what I thought. When I asked Robert what he thought, he said, 'I don't know.' How can you tell?" As we discussed this, Robert said, girls don't have dickies, boys do. I have a dickie, but I want to be a girl. I might be a girl. Maybe I was born a girl with a dickie." So this is like this conversation this person is having with Robert. Okay. This is where it gets hard, right? Like I have seen some of this unfold with different people I know personally and or with clients, right? And so there is a lot of things to take into consideration. Robert, this little kid, is having an issue. Feels detached from his body, doesn't feel like he associates with the gender he was born with, which I know we could probably get in all conversation with language as far as like the construct of gender and why there's gender and all those things, whatever. I'm not trying to downplay that. I'm just trying to talk about what we have going on here. So there's things to take into consideration with, who Robert is, what's going on at home, the separation issues with mom, very attached to mom. It sounds like there's some kind of dynamic going on there that's not super healthy. Wasn't quite certain how you identify what a male is. So we have to take in a lot of things into consideration. We have to look at, nature, nurture, all those kinds of things. We have to be careful, and that's where as clinicians, we have to be mindful of our agenda. We can't have an agenda. We need to just treat based on what's in front of us, how we handle these things, trying to meet Robert where he's at, like what's going on with him. What is it he wants? What's the outcome he wants? What's mom's concerns? What are mom's goals? Trying to navigate what's the next best thing for Robert. And not trying to push away our own thoughts and our own perceptions onto the client, onto the parent. We have to be very mindful of that. Now, I've had, older, kids, minors, adolescents who have come to me through the process of transition to some degree, and, biologically born female, but was choosing to be now male, identifying as male. And so I just went along with the program. Like they identified as male, so I acknowledged them as a male. Never once mentioned their dead name or how they were previously identified, because that's really important to people. And so I want to be respectful and be mindful of that. And the reality is the client was hurting. The client suffered a lot of trauma. There was sexual abuse in their history. This is what's so important to me, and this is something I advocate for when we're talking about transgender, transitioning, medical transitioning, things of that nature, is like whoever wherever you are, there you'll be. Like, just because you want to change your identity doesn't mean you still won't be the same person. And so if that has anything to do with the desire to transition, then we really need to navigate that, because that is not the reason to transition, because wherever you are, there you'll be. Like, the same problems will still be there. The same things you're trying to avoid will be there. It's not going away, which I think that sometimes that's what the case is for some people. I'm not saying all, for some. And so I think that's why therapy is so important for a person who is considering transitioning medically, and or someone who's in a time of seeking and trying to figure things out. I think therapy is so important. I think it's very medically negligent to proceed with some of the medical treatments for transitioning without proper mental health care. There is a lot of people who struggle with depression and or have suicidal ideation or follow through with suicide after transitioning medically. And that's obviously very scary, regardless of what your thoughts may be on any of this. I myself would never want someone to harm themselves or actually complete a suicide attempt. Like, that breaks my heart. I would never want someone to feel that terrible, that they proceed with that. And so, that's why I think it is really important that mental health professionals are part of this process to really help people understand what they're doing, why they're doing it, all those kinds of things, because it is a big deal. It is a very big deal. I have worked with parents as they adjust, to their family member transitioning, and it's hard. It's hard. Even if they're fully supportive, it's still, you gave birth to a child, you named the child, and then you're expected now to adapt to something that is very different and very different from what you birthed. Maybe even so they're getting rid of their name and they're calling it their dead name, which could be really hard because you named the person. You gave them that name, you raised them a type of way. And then, sometimes there's an expectation that you're just supposed to shut that off and accept what's in front of you. And sometimes that's an unfair expectation, even for the most supportive of families. You're going to love your child no matter what, despite what might be in front of you, but it's hard to just switch like that. And so I really challenge you to listen to the videos that we have that are working, to look over the text. It's not meant to offend anybody or upset anyone. It's just trying to get you ready for things that are going to be out there. And there's a lot of stuff that's out there. My job is never dull. Never dull. But please be thoughtful in your responses. Be thoughtful with people, there is too much ugliness in our world. We don't need to be that way with each other, and we don't need to be that with our clients. If they had people, they wouldn't need to talk to us, and a lot of them don't. So we gotta meet people where they're at and try to be the best version of ourselves for whoever it is that comes in our office facing whatever it is they're facing. Looking at their humanness, looking at them with their pain or, their struggle, and just trying to come alongside them and join them on the journey. That's our job. So, I wish you all the best. I hope you have a great rest of your week. Only a couple more weeks left and we're done. You're done with your 8-week course. On to the next one. So, again, have a great day. If you have any questions, just let me know.